I would like to introduce my friend, Dr. Bansi Sabu, the president of National RSSGI. Welcome to the platform, Bansi. It's a great pleasure to see you. And we all know his passion for type 1 diabetes. And I think nobody better than him to talk about that. Are we doing enough for type 1 diabetes in our country? And I'm sure he'll have a lot of data to say as where do we stand with type 1 diabetes out here in our country. Over to you, Bansi.
First of all, thanks, Sanjay, for giving me an opportunity. I'm really honored. And thank you, the complete IDEC team, including Dr. Neeta, Dr. Anjali, Dr. Archana. So I'm just sharing my slides. So once again, thank you. Thank you for giving me an opportunity. What my talk is, are we doing enough for type 1 diabetes? And that I will be finishing in next 15 to 20 minutes. Are we really doing enough for our patients? I don't have any conflict for making this talk. Type 1 diabetes accounts for 5 to 10% of all cases of diabetes. It is a complex, expensive, exhaustive disorder for a child and family to cope. Incidence of type 1 diabetes continues to increase worldwide, and it has serious short-term and long-term implications. The incidence and prevalence of type 1 diabetes is suspected to be high in India, but in the absence of nationwide registry, it is not possible to be sure of the number. So we don't know how many patients actually we have in our country, but the Atlas of IDEC in 2019 estimates that there are around 128,500 children, 128,500 children with diabetes in our country. However, this data had come with extrapolating a data from a 0.54 per thousand population in Indians who are staying in UK. That figure translates roughly to the prevalence of 9 lakh children in a population of 132 crores. So actually, whatever the IDF data is talking, it is as per the data which had shown from India is around 128,000 people, while if exactly the figure if we get from this UK data, it comes almost like 900,000 children with diabetes in our country. But the point is, if they all are diagnosed and they all survive, then probably we may have these many number of persons with type 1 diabetes. But whatever it is, still we are having second highest number of type 1 children in our country after the US population. So US is having highest number of type 1 children. Still our incidence and prevalence is in compared to North America and North Europe is less, but because the size of the country and the population is so high, so that's the reason we are second highest in the world. Where all these children are disappearing. Now that's very important question. We all see so many adults which are type 2. We don't see so many adult type 1. And we see a lot of type 1 children. Why they are not in adult form? Why they are not seen in adults? It has been indeed long been suspected that many children were dying before or even soon after the diagnosis. I will not say soon after the diagnosis. Many of them are dying because of complication maybe after 10 or 15 years. Despite major advances in management and care, type 1 diabetes remains associated with considerable premature mortality. Even whatever the treatment which has been given in our country, they are dying and they are dying prematurely. And that's the reason I'm telling we are not doing enough. Type 1 diabetes have mortality rates which is 3 to 18 times higher than would be expected in their respective countries. Diabetes-related chronic complication, particularly renal disease, which is more common. If they survive enough, then they may die because of macrovascular complication like type 2 diabetes. They develop also cardiovascular disease, in contrast to high rates of death due to diabetes-related acute complication. But that may not be true for our country because we have many patients who are dying because of acute complication of type 1 like hypoglycemia and even in diabetic ketoacidosis also. But there is a changing phase which is happening in our country. So it's not like that whatever the data or whatever the statement which I have made, it may not be true now today because as country experiencing reduction in poverty, there is a better communication, better in technology, greater awareness among healthcare professionals, as we are doing with multiple such conferences now everywhere we are talking more about type 1. So definitely the greater awareness had come in healthcare professional and more trained specialists which are now there in our country. Situation appears to be improving and we may have more patients with earlier diagnosis and we may have more persons with type 1 diabetes with increased survival also. The full effect of modern management of type 1 diabetes on mortality still we don't know, but however the long awaited data from DCCT and IDEC study suggests there is a reduced mortality if there is an intensive therapy. So now we know that if we are intensively treating these type 1 children, probably there will be reduced mortality also. The higher proportion with onset before 5 years of the age, 97% of the patients now they are on multiple daily insulin regime, and almost half of them are on basal analog or the lower rates of retinopathy. This particular paper had come from a tertiary care from SGPGI, which they are talking now their patients are maximum number of patients are on multiple daily insulin injection. But this may not be true for all across the country. We may not have all patients who are having type 1 diabetes, all of them are on type 1, on multiple daily insulin injection. That I doubt. The quality of life can be abysmal and worsen with the frequent chronic complication which type 1 diabetic patients may have. So managing type 1 diabetes is like walking on a very tight rope, where one side there is a lot of chances the person may go in hypoglycemia, and there's also a limiting factor for a tighter glycemic control. And one side, the hyperglycemia, which leads to more microvascular and macrovascular complication, more of microvascular complication in type 1 diabetes. It's a 24/7 jugglery for a type 1 diabetic persons, along with the caregiver and family also, the constant juggling between insulin and medication, exercise, food intake, and there is a broad range of activities. These children who are visiting the doctors, maybe their general practitioner, pediatrician, or even to the consultant diabetologist or endocrinologist, maybe 4 times or 6 times in a year, but other time 24/7 they have to manage their life, which is not inside the hospital, not inside the clinic, rather it is in their home, inside the school or the society, which includes broad range of activities, different physical activities and activities of daily living. And that's the reason there is a constant juggling between the insulin and monitoring and the whatever the food which they are taking. But there is a low level of awareness which is seen in patients as well as caregivers. So what we are saying that we are not doing enough for our patients as far as education is concerned. We might be writing them multiple daily insulin injection. We might be giving them all other things, but we are not educating, and that's a very big problem of increasing the awareness in the patients as well as for their caregivers. There are multiple challenges. This challenge has been talked about before almost 10 years, but still I see after 10 years, after a decade, still the challenges are the same. It is not only the insulin therapy, which is still we are seeing a lot of patients on a premix insulin therapy. We see the patient insulin dose adjustment, or we are not empowering the patients to do itself by themselves. The self-monitoring of blood glucose, they are not monitoring the blood glucose more than once in a day, or many of the patients even once in a week also. The hypoglycemia is still a major challenge for our patients for type 1 diabetes, and managing other problems like early optimization of glycemic control, psychological aspect of the disease, or managing all other cardio-renal risk factor in type 1 diabetes patients. The all challenges still remain even after 10 years or 20 years of these advancement in therapy. The glycemic targets for our patient in HbA1c still it should be less than 7 as per international guidelines. The International Diabetic Federation as well as the they are talking slightly tighter glycemic control if we can keep it less than 6.5 without getting hypoglycemia. And those patients who can't achieve because of severe hypoglycemia or risk of hypoglycemia unawareness is very high or limited life expectancy, these are the patients we are okay with less than 8. But and now the new parameter had come. It's for type 1 diabetes. More powerful parameter is there now, time in range. Instead of going for a HbA1c of less than 7 or less than 6.5, our patient should achieve a time in range of more than 70% of the time in 24 hours. They should be between 70 to 180, and that is what we want to achieve in our patients. But are we doing for our patients what we are achieving in our country? Most of our type 1 diabetic patients are around 8.5 to 9.5. And these are the data which I am telling you from the centers which are dedicatedly doing work for type 1 diabetes. They are endocrine department, they are dedicated diabetologists who are working for type 1 diabetes. Still their published data is showing in our countries around 8.5 to 9.5. So it means we are not doing enough for our patients. We are not able to get for our patients time in range because many of our patients are not doing even continuous glucose monitoring. So then a new term had come, are we getting point in range? That is a person who is checking sugar more than 4 times in a day. Out of 4, at least 3 of them, the report should be between 70 to 180. That is what point in range. If you get in 28 reports or 25, more than 25 reports in a week time, we can check that how many sugar reports are exactly in the range, that is between 70 to 180, and that new term had come is a points in range. And most of our patients are neither doing multiple time sugar monitoring and they can't afford continuous glucose monitoring. So we are not able to get this new glycemic parameter for our type 1 diabetic patients. Most patients, they develop hypoglycemia either because of premix, many of them are still on NPH or on regular insulin, and that's also one of the major reasons for not to reach their target. And that is the reason we are not doing enough for our patients. Our patients are not monitoring, self-monitoring of blood glucose, which is minimum 2 to 4 times in a day. The glycemic control definitely reduces the complication rate. We all know from DCCT trial that tighter the glycemic control, lesser and lesser complication. But at the same time, to achieve a tighter glycemic control at that point of time in DCCT trial when it had happened, the 60% of the patient had severe hypoglycemia. And even after 30 years, we are seeing in our country, or 40 years, we are still seeing the patients who are trying to achieve a tighter glycemic control, we still get a lot of hypoglycemia. Maybe one of the reasons is we don't have our patients on continuous glucose monitoring, or they are not tightly monitoring their patient. So despite multiple advancements, there are many barriers with the patients with type 1 diabetes. And one of the biggest barrier is lack of awareness at the community level. And this community level awareness is so poor that still our type 1 diabetic patients goes to some Baba to take the cure. I mean, and the Babas are also claiming for the cure for type 1 diabetes. So that sort of a awareness is in our society. The poverty and lack of resources, some of the family who can't afford for their children the insulin, even they are getting the insulin from some of the foundations or some tertiary care hospitals or the private or public hospitals, still they can't afford to go and reach to these clinics because the cost of transport for them is very high. But biggest problem is the poor understanding of childhood diabetes at the primary care physicians as well as the consultant pediatrician and physicians. So they are not understanding this childhood diabetes. It's not that trying to treat the childhood diabetes in the similar way, the way they treat the type 2 diabetic patients. There is a weak healthcare system, lack of awareness, cultural misunderstanding, and stigma of showing or telling someone that they are having type 1 diabetes. And that's the reason even in the school, they don't tell the the school teachers, and they just take one shot before before breakfast and the mid breakfast or the lunch which they are taking in the insulin. Many of these children, they don't take even insulin in the school also. So what we are trying, if we are one side, we are saying that we are not doing enough for our children. So what we are doing as an RSSDI president or as an organization or across the country, many of the diabetologists and endocrinologists, we are continuously educating our healthcare providers. So one thing which we are doing constantly since last 10 years or 15 years by different way or in different conferences, now at least 10% of it is covered with type 1 diabetes. So continuously we are educating our healthcare providers. Second thing, we are providing free insulin and glucose meters to needy patients. And this we are doing through different projects like Changing Diabetes in Children. More than 4,000 children are supported with the help of that. Life for Child, which is again a project with more than 3,500 children are supported by them. RSSDI Type 1 Diabetes project, which we have started this year, where 1,500 children are supported with the help of Sanofi, and another 1,500 we are going to support with Vocard with their insulin also. So I mean, this is what we are already supporting more than 10,000 children in our country, and probably in coming years we may do more. Establishing type 1 diabetes network, which we have created across the country. We have a task force under the RSSDI, and we created across the country a network for that. And then we have also created a young leaders who are already type 1, and we educated them, and now they are the educating other children. We have also created a tie-up for online educating our Indian doctors. This is a type 1 education UK program with the help of Indian doctors who are practicing in UK, practicing type 1. They have created a modules for our Indian doctors, modules for educating caregivers as well as person with diabetes. And there are more than 100 foundations which are working in our country to support and educating these type 1 children. So there are multiple things which we are doing, but still we are not doing enough, because at the end of the day, how many of them are surviving, how many of them are getting complications, and how many of them are diagnosed early, that is what the parameters which we are looking for. Now, why it is not changing in our country? One of the important reasons is, if you see the data from the Western world, the usage of insulin pump is very, very high. The second reason is the patients who are taking 4 to 6 injection, almost more than 50% of their patients either on multiple daily insulin injection, not just 3, they are taking 4 to 6 injection in a day. And either they are on insulin pump therapy. Why it is required? Why we should give the patients more insulin number of pricks in a day? If you see the data, that those patients who are taking more than 4 to 6 bolus in a day, their sugar control is much better in compared to the patients who are taking 2 to 4 bolus or less than 2 bolus. So this is important. Our patient should be not only on multiple daily insulin injection, they should cover with all the meals. If a child is going in a school, the school they should take in morning, then in mid breakfast, then again in lunch, then again in afternoon snacks, and again maybe in evening time dinner, and some of them in a late evening dinner or supper. They should also be covered with the short acting insulin. So more the bolus shots are there, they get a better control in compared to the patients who are taking only 2 to 4 shots. And we are seeing many of the children who are just taking 2 premix. How it can control? It is just going to have no hypoglycemia, and never the patient is going to have a good control of diabetes. And most of these patients are on 9 or 9.5 HbA1c. The advantage of pump is not just only for the basal insulin dose to get adjusted. It is also for multiple bolus which we can give with the pump therapy. So this is one of the biggest advantage with the insulin pump, because a insulin pump, you can adjust the dose of basal insulin multiple times. A child has not to take, or a type 1 has not to take just 24 hours the same amount of basal insulin requirement, while the person with type 1 diabetes, their basal insulin requirement throughout the 24 hours, it can be different. In midnight, it could be less. In evening time, when the person is doing exercise, at that time it could be raised. So that's the biggest advantage. And the second big advantage, they can take multiple shot of the short acting insulin analog with the help of insulin pump, which is not possible if somebody is on a multiple daily insulin injection. What we are seeing that a child has to take, if minimum 4 shots in a day, then 1460 shots in a year to stay alive. And that is number of shots a child has to take. This is a picture which is posted by a mother of this child who just wanted to increase the awareness about the type 1 diabetes. Otherwise, this child is probably not taking insulin through this insulin syringe, because here there is a direct cap. She's already on the pump, and on the left side, she's also on Dexcom continuous glucose monitoring too. Insulin delivery devices which improved over a period of time, and what the standard of diabetes as per American Diabetic Association, which is published in 2020, what they are saying, insulin syringe should not be used. I mean, that's a evidence C, which is coming for the insulin pump or insulin pump or insulin pen. They are the one which should be used for the patient with type 1 diabetes. So forget the insulin syringe. This is what is internationally recommended. And what we are using insulin syringe for, more than 60% of our patients or 70% of our patients are still on insulin syringe. And that is what we are not doing enough for our children. We are still struggling for many of our patients for financial constraint, for better clinical attendance. Even we are giving them free insulin, still they are not able to come for regular to show our patients. We are not able to satisfy our patients or educate them completely, improving their psychosocial outcomes, and ultimately the A1C is still very poor. So glycemic control leaves much scope for improvement, and that's what the reason why we have created a type 1 diabetes network, because still are many of our patients are not achieving a good control for that, even at tertiary care centers and where they're having multidisciplinary teams. MDI is possible. Many of our patients started now, but those in rural area and many of the physicians and pediatricians still using the premix insulin. Please use only multiple daily insulin injection. That has to be, if patient can't afford, at least use the NPH and regular insulin. So the best case scenario for a type 1 diabetes, a correct diagnosis, a education for self-management, a peer support, a psychological support, access to a specialist, and access and knowledge of technology that should be provided to these type 1 children. They need a very holistic support. They need infrastructure. They need healthcare professional training and education. Many of them may need free insulin and supply. The patient education, and one very important thing, which is a diabetes registry. Unless we have a registry, how many patients in our country are having a type 1 patient, and what supply, what they are having, and what is their sugar control. Unless we have a registry, I don't think we will able to improve the holistic support for these children. So the advocacy and support can be improved only by having a diabetic registry in our country. We know that few statistics which we cannot ignore and we can't change. A type 1 child or type 1 person with diabetes has to take minimum 4 injections in a year, and he has to or she has to measure minimum 1 to 7 tests per day. So these many two things we cannot change for our type 1 patient. But our role begins as in healthcare professional. We are like a coach. The child is a player. He has to play, but we are like a coach. We continue as a friend who support children to live a healthy life. Diet, exercise, hormonal changes, sickness, exams, traveling, stress, rejection. So many things, they affect blood glucose level, and that also we have to accept as a doctor as well as the caregiver for these children. Are we doing enough? I will say no. It's a big no. We don't have the registry. Our patients still getting delayed diagnosis. There is a lack of education for caregivers, parents, and patients. You may not say that individual centers are doing good, but we have to talk for nationwide. Are we doing enough? We will say no. The insulin delivery system is still, we are struggling for pain. Forget about the pump. In India, only 10,000 patients are on pump. Out of them, only 5,000 patients are actually type 1 diabetes. And out of those 5,000 patients, only 500 patients are on sensor augmented pump. And they are also not using the sensor augmented sensor regularly too. There is a poor access for regular checkup. Even we have a lot of diabetologists, endocrinologists, more than now 2,000 endocrinologists and even pediatric endocrinologists and more than 5,000 diabetologists. Still them access for regular checkup is really very poor. Use of technology in our healthcare delivery and particularly type 1 is very, very less. School education is again poor. Psychosocial problems are very high, and healthcare professional training for pediatric diabetes is suboptimal. Even we are continuously trying for it, still training for them is very, very less, because we have 100,000 physicians and 100,000 pediatricians and maybe another 300,000 primary care physicians, and to train them for type 1 is really very big task. And that's what we have created, a type 1 diabetes network under RSSDI, a mission to build a positive ecosystem for type 1 diabetes care pan India to the last mile. Type 1 diabetes we cannot prevent and we cannot cure. So nothing like someone can reverse it, someone can cure it. I mean, that's very important message which we have done for 10 days, continuously educating our laymen or to the society regarding the type 1 cannot be cured. A continuous social media bites under the RSSDA which we have done. We know that it increased with a risk of early mortality. Fortunately, this is no longer the necessary case. Now, as I told you, now there is a improving, at least there is a definite improvement in care for type 1 diabetes. That much what I can say. So that pessimist may see the glass half empty, but the optimist can see the droplets gathering into it and the levels slowly rising. And that's what I am thinking for our country. Thank you. Thank you very much. Once again, thanks, Sanjay, for giving me this opportunity. Thank you very much.
Thank you. Thank you so much, sir, for such an intimidating yet inspiring talk. Is really nothing is enough for type 1 diabetes. Thank you.